Alright guys, welcome back. We are talking about hypersensitivity reactions and we are starting with the type 1 hypersensitivity reaction. Very important type of reaction, very common encounter in the hospitals and in the patients. Sometimes actually it's a great risk for the health professionals in two ways. Latex gloves and others, these are actually direct reaction to the direct impact, negative impact or possibility of allergies for the health professionals. And secondly, sometimes in the clinics, and I've seen this many times, sometimes in the clinics if the injections are administered to the patients that are allergic to the drug and the injection is administered without taking a skin test, that can really go bad. So very important thing to keep an eye on. So type 1 hypersensitivity reaction, so let's talk about it. First of all, it can be divided into two types, local and systemic anaphylaxis or anaphylactic reaction. So that is the first thing, that the type 1 hypersensitivity reaction, also called allergies, can be divided into local anaphylactic reactions and systemic anaphylactic reaction. So let's see first of all, what does anaphylactic reaction mean? So phylactic or phylaxis means to stand guard, to watch out for something, to help for something. So prophylaxis, I'm sure that you have prophylaxis, you have read that in the pharmacology. Pro means before, phylaxis mean to stand guard or to prevent or to protect. So to protect before something happens. Anaphylaxis means to against the standing guard. So we are actually trying to do some help, but instead of the help, so help may be by, so what happens was originally the scientists who were conducting tests to prove out the type 1 hypersensitivity reaction or to explore about it, what they did was they took the tissue fluids from the animals that were showing reactions and injected them in the other animals, and what happened was when they do inject them, then the reactions would occur in the other animals. And so they said that as a result of injecting the drug, instead of curing, there appeared to be a reverse action. So that is reverse standing guard or reverse protection. That means something went wrong. So that is why it is called anaphylactic reaction. So local and systemic anaphylactic reactions, then the rhinitis, conjunctivitis, hay fever, and other such allergic reactions. So now what happens is, what are the causative agents for the type 1 hypersensitivity reaction? So the causative agents are environmental agents. What does that mean? So in this we can talk about proteins, for example egg proteins. We can talk about seafood, peanuts, then sometimes rye and other such pollen. Very common are pollen, dander, dust. So dander is interesting. Dander itself coming from the hair. So the hair themselves are not allergic or allergens. However, the epithelium that comes with the hair can act as allergens. So the dander for the cat and dog dander, the allergen in there is really the epithelium, the skin surfaces of the cats and dogs or other animals. So these are environmental agents. Now remember, there is a genetic predisposition. Why does this happen? There is a genetic predisposition. So let's talk about that first of all. Why does allergic reactions occur? So it turns out that allergens are those substances or agents or mediums that in 80% or more of the population do not cause any harm or do not trigger immune system to react, right? So antigens compared to allergens, antigens are the substances that will create reaction in all parts of a species. So for example, staphylococcal bacteria that invades my body or yours or somebody else's body would react to it, normal body would react to it. However, pollen, for example, I do not have allergies from pollen. So when pollen is ingested or inhaled in my body, there is not much immune reaction. There is an immune clearing of the pollen, but there is no inappropriate immune reaction. But my son has pollen allergies. So whenever the pollen season comes around and he goes out into the area where there is pollen and he inhales the pollens, his body reacts to it and he gets allergic reaction to it. So important thing to note is that type 1 allergic reactions are caused by allergens, and allergens are the substances to which only 20% or lesser of the population reacts and 80% does not. Now the question is, why is that so? Why only 20% react and the others not? So there are a couple of theories for this. So why the type 1 reaction? So there are a couple of theories. One theory is called hygiene hypothesis, and the other theory is the genetic predisposition. So let's talk about it, both of them one by one right now. On the genetic predisposition, what they have found out is that in some patients, in some people, through the familial predisposition, that means from their parents, one parent or both parent, they receive genes that have an interleukin 4 receptor modification. So where is this receptor present? This receptor is present, the location is on the B cells. Location is B cells. So when B cells, so remember whenever the antigen or some allergen would come into our body, a normal person would respond and the allergen will not really be active. But let's say a person who has this problem, in that person when the allergen comes in, macrophages are going to process that. We will talk about it in a second. I want to make a point here. Macrophages would process that, helper T cell would release IL-4, that IL-4 would act on the B cells. B cell in turn have genetically modified receptor for the IL-4, and that receptor causes hyperactivity, and what happens is a lot of class switching occurs, and that results into IgE production. So one of the issues is abnormal levels of IgE produced in these people, and that is a genetic predisposition. So such folks, such patients are called atopic. Atopy means a familial predisposition to the allergies. So atopic patients, if for example both father and mother are atopic, if this is the case, then 50% are the chances that the baby will be atopic or allergic as well to environmental agents. If just one of them is atopic, then it's about 30 to 35% chances that the baby is going to be atopic. So in my case, I think I do not have allergies to most of the things, but my wife has allergies, and so these are translated into the children as well. So these parents or these individuals are atopic, and this is called atopy. The other theory of the IgE, extra IgE, so the culprit in this case is increased level of IgE. That is a culprit. That is a root cause. That is an issue. So increased level of IgE, one is a genetic predisposition for atopy, the other is hygiene hypothesis. What that means is, I think we've talked about it in our previous lecture, especially the eosinophil lecture, that IgE and eosinophil are responsible to fight with helminths that invade our body. So it is a very important antibody that is used for fighting with the helminths. In the countries where the burden of helminths is less, where the hygiene is kept such that the helminth burden is less, in such countries the people have IgE freely available in the bloodstream. Of course, when it is free, it is not used up to fight parasites, then that IgE will go and get loaded on the mast cells. So once it is loaded on the mast cells and basophils, then the mast cell degranulation would start causing the allergic reactions. So the hygiene hypothesis is that those countries that have less burden of the parasites will have more IgE available in the patient's body, and that IgE will be loaded on the mast cells, and as a result will have the allergies. On the flip side, the countries where there are parasitic infections most often, over there the IgE is consumed to fight with the parasites, and so it is not available, not enough IgE is available to load onto the mast cell and cause the allergic reactions. So that is another hypothesis. So anyways, this is a proved situation for the DNA or genetic modification. This is a hypothesis. So now we know that type 1 allergic reactions are the reactions to the environmental agents. The type of environmental agents are eggs, seafoods, peanuts, rye, pollen, dander, dust, and then there is genetic predisposition, there is hygiene hypothesis. The types of diseases that come into this are anaphylactic reactions, local and systemic, and you know that systemic anaphylactic reaction is very dangerous. It can actually kill a patient within a few seconds to minutes, and so needs a lot of support. On the other hand, local reactions are, sometimes when the seasons come around for these kind of things, you would see that there would be rhinitis, or some people develop conjunctivitis or mild gastritis and so on. So it can be the issues can be mild to severe to the point of killing a patient. So now let's talk about what is the mechanism of type 1 hypersensitivity. That is very, very important from a USMLE point of view, and that is very important from a practicing doctor's point of view. So let's talk about that. Of the type 1 hypersensitivity reaction or mechanism for allergies. So the main player, as we talked about a few minutes back, the main player is mast cell. The question that we need to answer right now is, how do we make mast cell capable of reacting or taking part in this allergic reaction? So let's see how the mast cell is prepared to get to the point where it starts creating allergic reactions. So let's start with this thing, that we have a patient, let's say I am that patient, and that patient is going to be allergic to pollen allergen. So this is how it would happen. The very first time in my life when I get exposed to pollen, the pollen goes through my respiratory system, goes into my lungs. Somewhere in the lungs there is the mast cell macrophages sitting in there, and they are going to ingest the pollen, they are going to take up the pollen. So here is the, let's quickly make it, let's say this is the bronchial tree, and let's make a little mast cell, actually macrophage, sitting here with the bronchial tree. So the pollen that reaches from the respiratory tract into this area, what happens is, so I am going to magnify this part, and so what happens is that the pollen is present, this is the pollen, and the macrophage is going to, so here is a macrophage, remember the big eater. So the macrophage is sitting there, he is looking at this pollen, and he looks ferocious. Look at that macrophage. So the macrophage is going to phagocytose this pollen and take it inside there. So let's make a pollen here that has already been phagocytosed, and the pollen is sitting here in this vacuole. So let's say this is the macrophage vacuole in which the pollen has been. Of course this is a closed vacuole, and I have opened it up to show that the pollen grain is present there. Now this pollen grain is going to be digested here. We have talked about it. This is I think second or third lecture of the immunology. We have talked about how the pollen is present inside the granule and it is going to be digested, pollen or pathogen. So now this allergen has been digested, and what happens is it is loaded onto the MHC2 complex and it is extruded out on the surface of the macrophage. So let us say here the one of the piece of this allergen is loaded and presented outside on the MHC2 complex. Now what happens is, remember, the MHC2 complex interacts with the T helper 2 cells, so T helper 4 cells. So what would happen here is that there are going to be some T helper cells present. So the macrophage is going to run to the lymph nodes, and the lymph nodes have gotten the T helper cells. There are going to be T helper cell present here as well. So wherever the macrophage is going to encounter a T helper cell, T helper 2 cell, that cell is going to, so let us make a quick T helper 2 cell here, T helper 2 cell. The T helper 2 cell is going to engage, remember there is T cell receptors, so that I believe T cell receptors is immunology lecture number 11, so you can listen to that if you have missed on it. So T cell receptor would interact with the MHC2, so let us say this is that interaction, and this causes the activation of the T helper cell. So what happens now is that the T helper cell proliferates, that means multiple copies are formed. We have discussed this in our previous lecture, so that is why I am going fast on this, because I think we have covered it. So the multiple copies are formed and then it becomes differentiated as well, or becomes active as well. And what do we mean by that? One, the things that it does is, number one, it releases IL-2, interleukin 2, that can act on its own self and cause further proliferation, but more importantly here it would be releasing IL-4, interleukin 4 and interleukin 5. Interleukin 4 and interleukin 5 are going to act on the B cells. Now what B cells this would act on? So this is a very important thing. So let us say we make a few B cells. These B cells may be sitting here in the area of in the vicinity of the respiratory system, or the B cells present in the lymph nodes. Wherever these B cells are present, there are B cells present here as well. So let us make one B cell. So let us say this is a B cell, or actually let us make 3 B cells. I want to make a point here. This is a B cell, this is another B cell, and this is another B cell. Now pay attention to this part, this is very important. I am trying to make a point here. This B cell, of course all of them have B cell receptors, right. So B cell receptors, what are the B cell receptors? Immunoglobulin D or immunoglobulin M. So the B cell receptors are present on all the B cells which are present either in the respiratory system or in the lymph node. Now this B cells receptor is not loaded with anything, it is not presenting anything, it has not caught anything. So this B cell is naive at this time, it is not presenting anything. Remember, B cells are professional antigen presenting cells as well, so this is not presenting anything. This B cell was also exposed to the same pollen, and it has taken that pollen in, and it is actually presenting the pollen antigen on its surface. So let us make this here actually, that the pollen antigen is being presented. So now this B cell is presenting the antigen or allergen or one piece of this pollen on its surface as well. This is another B cell, and this B cell is presenting. So let us say that patient, I am also exposed to some virus or bacteria, and that virus or bacteria or some other pathogen or antigen is also exposed on this B cell. So now there are 3 B cells sitting in this situation. One is a B cell that is not presenting anything, another B cell is presenting the allergen or the piece of the pollen on its presentation molecule, and the third B cell is presenting a different antigen from a bacteria or a virus. Now when the interleukin 4 is released and interleukin 5 is released, what happens is this interleukin 4 and 5 is going to be present in this environment. So here is interleukin 4, this is interleukin 4, and let us say that there is interleukin 5 as well. So there is some interleukin 5. Now what happens is, the point that I want to make, this B cell does not have, is not presenting anything, it is not loaded with any antigen, this is not going to respond to IL-4 and 5, this B cell is just going to sit and continue waiting. This B cell received the IL-4, and of course this also needs some interaction. Remember, the presentation need interaction with the other side. So let us say that there is an CD40 ligand and CD40, remember. So there is an interaction with the T cell, and that interaction, let us make that here. Now it is not necessary that same T cell that is interacting with the macrophage is interacting here, this may be a different T cell, just for our convenience I have made it this way. So there is a CD40 and CD40 ligand interaction here. Now this B cell is interacting, IL-4 receptors are present and active on this B cell surface. When the IL-4 will go there, this B cell would start proliferating. So it would start making copies of itself. So that is first point. This B cell is not reacting. Why? Because it does not have any interaction going on its surface. This B cell would react because it is interacting with the T cell. This B cell, what do you think? So remember, we are talking about the pollen and an allergen, a piece of the pollen that is going to cause some problem. This is not a piece of pollen, this is a piece of bacteria, or this is a piece of virus. Do you think that this B cell would become activated as well with the IL-4 which is released as a result of the allergen? So let us talk about it. Here is another T cell, another helper T cell, and there is CD40 ligand and CD40 interaction and co-stimulation and all that. We have talked about it in our previous lectures. So will this B cell become active due to this IL-4? Yes, it will. IL-4 is not specific to the allergen or antigen. IL-4 is a chemical substance, it is a molecule, it is going to go and attach to the surface wherever it would find a receptor, and those B cells that are presenting something on the surface would have receptors to have the IL-4 interact with them. So that means it is entirely possible that one T helper cell or a type of T helper cell that are activated due to one type of allergen or antigen will cause activation of multiple types of B cells, because all of these B cells are loaded with the antigen and they are waiting for the chemical substance signaling to occur. So this became active and the other B cell became active as well. Why did I talk about that? Just to make sure that we keep this in our mind, that chemical substances are not specific to the allergens or antigens, they are actually more generic. The systems that present the pathogens, these are specific. Now in this discussion, when we reach mast cell, we are going to make one more point over there, that one mast cell can react to more than one type of pathogens or allergens or antigens or antigenic agents. On the other hand, one B cell, remember clonal specificity or selection, one B cell can only react to one kind of antigen, whatever kind of antigen its idiotype can work with, only one antigen type. One T cell also can only work with one antigenic type or one whatever gets loaded on its idiotype or the T cell receptor. So one T helper cell cannot react to a, let us say, allergen or antigen of type 1 and one more antigen of a different type. So remember this, these are specific, and mast cell we would see that they are not specific. That is very interesting. Mast cell and basophils are the only cell in the immune system that get loaded with non-specific or multi-specific immunoglobulins, and they can react to more than one type of allergens or antigens. Please do not forget that. So now we have gotten this thing, and what happens is when the B cell differentiates, after this it would be, it proliferates, and after this it would differentiate. And what does that mean? Differentiation will mean that B cell would become active. So of course this one differentiates and this one differentiates too. We do not care about this, we are not talking about it, this B cell is sad B cell, but still we are just talking about it to say, hey, the IL4 and IL5's action is on both. Now the differentiation occurs and the B cell becomes a plasma cell. So this is a plasma cell here, and it has gotten this plasma or the big pregnant belly, as I say it. Why? Because it is manufacturing immunoglobulins, and these are present here. Now this B cell has become active and it would start releasing immunoglobulins. Same thing here as well. So now this is a proliferated and differentiated B cell, it has become active, it is a plasma cell, it is releasing immunoglobulins. Now what immunoglobulin would it release? How much time? We have talked about it in the B cell. This would take maybe the first exposure, this would take about 2 weeks. In about 2 weeks time the first exposure would cause this all the process to act, the immunoglobulins to form and be released. The very first immunoglobulins that will be released, we have talked about it, the first immunoglobulin released will be IgM. Then later there will be IgGs, right. So we have talked about it in our previous lecture, primary response and the secondary response. Now the other important thing is this, in the under the influence of IL4, IL4 is the player, just like mast cell is a major player for today's lecture for the hypersensitivity reaction type 1 or allergic reactions. IL4 is the second big player to remember. If out of this lecture you do not remember anything, just remember one thing, allergic reactions, mast cells are the primary reactants and IL4 is a primary causative problem. So IL4, under the influence of the IL4, the class switching would occur and the immunoglobulins would go from IgM, IgG, IgA and finally will start producing IgE. Finally will start producing IgE. If there is excessive IL4 or if the B cells are more sensitive to IL4's action, then IgE would start getting produced very quickly as well. So this is the very first time, we will continue talking about the IL4 and IgE, but remember that this is the first exposure. The first exposure caused this all and IgE got produced. This IgE that is produced, if we come back here, the mast cells. Now where are the mast cells present? Mast cells are present, as we talked a few minutes back, mast cells are present in the respiratory system, they are present in the mucous membranes, mast cells are present under the mucous membranes of the GIT system, they are present under the skin, 10,000 mast cells per millimeter cube, that is a very high density of the mast cells present in the skin. That is why these are the viscera, or these are the areas of the tissues that show the reaction to the allergies, and what happens is the skin starts showing hives and eczemas and urticaria, and the respiratory system is the principal shock organ and that becomes totally whacked and it is a life threatening problem, and the GIT becomes upset and the vomiting and diarrhea can occur. So mast cell are present in all these 3-4 visceras. So let us say there is a mast cell present here, so I am just going to make a bigger mast cell. This is the mast cell that is present in the respiratory system. Actually let us talk about all the mast cells present in the respiratory system, mast cell present under the skin and mast cell present in the GIT. All of these mast cell will have this IgE start to load on them. This IgE will load on them. Why? Because mast cell have a receptor onto them, and we will talk about that receptor shortly, called Fc epsilon or eta for the E receptor 1 and Fc E receptor 2. There are 2 types of receptors for the IgE crystalline portion. So the question is, remember I talked about it a few minutes ago, that helper cells, B cells, are specific to one kind of antigen. Mast cells are not specific to one kind of antigen or allergen. The reason is mast cell acquire IgE, they do not produce IgE inside. These things produce their chemical substances which are going to work with the allergen or antigen in their system, and then they produce it outside on the surface. Mast cell actually acquires IgE, it only has to have a receptor. So it does not matter if I am a mast cell and there is a free floating IgE coming across, I am going to hold it. This may be an IgE against pollen. I am a mast cell, the same mast cell, and this is another IgE that is free floating and coming, and this is against the egg proteins, and that gets loaded on the IgE as well. So one mast cell may actually end up having the IgEs loaded onto it that are reactive to more than one kind of allergens or antigens. So again, that is a very important thing. So this means one mast cell may actually have the capability of responding to more than one kind of allergens. Please do not forget that mast cell basophils are the only two cells in the immune system that can get loaded with the eosinophils get loaded with the IgE as well, but not exactly this mechanism. So these two cells, basophils and the mast cells, are the one that get loaded with the IgE. So this is the first ever exposure, the life of a baby. When I was a baby, I got exposed to the pollen. Well, by the way, I am not allergic to pollen, so this is just an example. So when I was a baby, I got exposed to the pollens, and this is the very first thing that happened. IgE was produced, and that got loaded onto the mast cell. So what do you need to be able to think and reproduce is how the mast cell got loaded. Now that very first exposure, nothing happened to me, I am fine, I just got my mast cell loaded. You can think about it as the gun got loaded. Next exposure, the gun is going to fire. Next exposure, the problem is going to appear. First exposure, loading occurred. So now let's go, I am going to delete this and erase this, and I am going to talk about the second exposure. Okay, so now okay. So the life of the baby, next year he gets exposed to the pollen again. So now the pollen comes in the mast cell. So I am going to take a bronchus here. I am going to take a bronchus and I am going to make it slightly bigger here. So let us say this is a bronchus. Now the bronchus, of course, the histology, you know that there is mucosa and submucosa and so on. We are not concerned with the histology that much here, as much as we are concerned with the mucosal part of it. So let us say this is the bronchial epithelium. This bronchial epithelium has, so let us say these are the epithelial cells. Now remember, okay, so the granule are loaded by histamine, serotonin, some chemotactic factors and proteases, and these are present in here. So it has gotten histamine in here, serotonin in here, some proteases in here, and chemotactic factors. These are present in the mast cell, in the mast cell granules. Now the result of the calcium increase is that the granule is going to be moved towards the cell membrane and degranulation would occur. But let us continue looking at it for the time being. Here we have gotten the PKC activated, we have gotten the calcium received. Then what happens? That is one action. The second action is that the cyclic adenylate cyclase, so AAC in the membrane as well, adenylate cyclase enzyme becomes active as well. And what is the function of that enzyme? It is adenylate cyclase, it creates the cyclic AMP. So what it would do is this enzyme is going to convert ATP to cyclic AMP. So cyclic AMP level are going to rise. The cyclic AMP has a very interesting action inside the mast cell, or for all the degranulations, that the cyclic AMP level, when that rises, that causes the granules to start swelling up. So the granule would become swollen, number one. Number two, the snare proteins on the granule would start facing outwards, snare proteins, SNARE. The snare proteins are also present on the membrane, snare, remember snare and snap proteins. So snare proteins are present, they are going to actually, for degranulation it is important that the snare proteins come in and they connect with each other, and that is how the degranulation process would occur. So cyclic AMP has a very important role, and that is that when the level increases, the granules become ready to be degranulated. However, this is very interesting. If the cyclic AMP level stays high, then the degranulation will not occur. Cyclic AMP level going high prepares the degranulation process, but if it stays high, the degranulation will not occur. So what happens is there is a transient effect of increased cyclic AMP and then decreased cyclic AMP. At the time of the increased cyclic AMP, so if this is cyclic AMP chart here, cyclic AMP has to increase. When this happens, the granule is prepared to be, so there is preparation for the granule to be degranulated, but then cyclic AMP level has to go down for the degranulation to occur. If the level does not go down and it is maintained higher, then the degranulation will not occur. This is called the mast cell stabilizing effect, and there are drugs, for example epinephrine does that. There are drugs that would actually keep the cyclic AMP level higher and prevent the degranulation, or they would cause the cell stabilizing effect. So please do not forget this. Now the third thing that would start happening is that there will be phospholipase C enzyme activated as well. So phospholipase A2 enzyme activated, so C was activated already. So phospholipase A2 will become activated, and you must have read this in the arachidonic acid pathway that once the phospholipase A2 becomes activated, it is going to pick up the linoleic acid from within the cell membrane. Remember, fatty acid, linoleic acid, and it is going to convert that into arachidonic acid. Once the arachidonic acid is created here in the cell membrane, that will be that arachidonic acid. So let us say this is the arachidonic acid, let me make that over here, this is my little scratch area. So arachidonic acid once created will go through two pathways, one of the two pathways both cyclooxygenase pathway and lipooxygenase pathway. Cyclooxygenase pathway is going to give rise to prostaglandins, and lipooxygenase pathway is going to give rise to leukotrienes. So this process starts occurring here. Now remember, this process is not immediate, so this manufacturing of prostaglandins and leukotrienes will not occur right away. So within 30 seconds to 2 minutes to 30 minutes, what will happen is that the granule would start degranulating. After that, for about 2 hours there is a lull, there is a pause, there is a slowdown of the action. Then within 2 to 8 hours window, these things will be created, and these will be released as well from the membrane of the mast cell, and this would create the second phase of the anaphylactic reaction. So please remember, as a doctor, as a health professional, as a nurse, when you are looking at a patient who is allergic, the very first thing you are seeing is the immediate reaction, and that is the result of the degranulation of the preformed substances present in the mast cell granules. That is what is happening. But after 2 hours and between 8 hours, there will start another cycle of mediators. There would be another attack by the mast cell, and now the second set of mediators will be released, and they would create another action. So let us talk about that in a second, but let us see what happens with the immediate. So remember this now, that I am going to go here for a second. The type 1 reaction will come in two phases. The first phase is going to be 30 minutes to 2 hours, 30 seconds to 30 minutes, and this is where the degranulation of preformed material is happening. So these things that are already present in the granules, these will be released out, and we are talking about it, that how these will be released out, but remember that would happen. Then within the 2 hours to 8 hours window, so 2 hours to 8 hours window, there will be another set of chemical substances released, and these are the ones that are prostaglandins and leukotrienes and some cytokines. We will talk about that in a second. So there will be second or second phase of the reaction or delayed reaction. Now the difference between them is that the first phase of the reaction is because of the histamine and serotonin and the chemotactic factors. The second phase is because of the prostaglandins. So what we say is that the second phase is inflammatory reaction. So second phase is actually heavily predominated by inflammation process. First phase is not inflammatory process. So please remember this. First phase is not inflammatory process. This is simply vasoconstriction. This is simply vasodilatation, venular permeability increase, bronchoconstriction. So this is simple effect of histamine and other substances. However, the second phase, prostaglandins and leukotrienes and some cytokines that would come in, that would be inflammation. So when you are treating the patient, the treatment for the first phase is different from the treatment for the second phase. So let us go back for the first phase here. So we talked about PLC and we talked about the cyclic AMP or the adenylate cyclase enzymes. These two enzymes are responsible to create the first phase reaction. Now what happens is, as part of this reaction, the what is that, granule that has become swollen. Why did that become swollen? As part of these enzyme activations, the membranes, they become more fluid, and when the membranes become fluid, remember, as part of PLA2 activation, there are calcium channel creations in the membrane as well. Calcium channels are created, and that also bring calcium inside the cell. How did these channels get formed? These channels get formed because the fluidity of the membrane would increase, and that fluidity would allow the channels to be formed. The same thing is happening to the granules as well. They are cell membrane bound. The granules have a membrane that is similar to the cell membrane. The end result is that the calcium, that when that comes in, that would create microtubular networks. The cyclic AMP would prepare the snare proteins, and finally the granule would go and get attached to the cell membrane through the snare proteins, and then it would open up and the degranulation would occur. Beautiful mechanism, I love this mechanism. So now the substances which are present here, these substances will be released. So degranulation occurred. Now where is this degranulation happening? This degranulation is happening here. So I hope you can zoom in here. This degranulation is happening right here in the mucosa of the bronchus. This is also happening right under the skin. This is also happening in the mucosa of the GIT. So it is not only the bronchus, but why is this important? Why are we talking here? Because the respiratory system is the principal shock organ. The major problem is going to happen here, even death can occur. So we have to be very, very thorough and very clear as medical professionals to understand what is happening here. So now the degranulation occurred here. What is the result? What is happening? So let's talk about that. When the degranulation occurred, we got the release from the granule. The substances that are released are, number one, histamine. Histamine's action is multiple. So if you sum up all the actions that would happen in this area, the actions are going to be, number one, glands would start secreting more secretions. So glandular secretions would increase. That is what is going to cause congestion, coughing, and problem in breathing. So that is one. Phlegm would start getting produced. Patient is going to start having breathing problems. So histamine actually increases mucus secretion, one. Second, the permeability. So if I make a blood vessel structure here, let's say this is an arteriole with the prearteriolar sphincter, then we have a capillary, and then we have a venule. So please pay attention here. This is venule, arteriole, and the sphincter. The action of histamine is that it dilates the sphincter, and that would increase the blood flow through the capillary and vein, and of course that would cause more blood, more fluids to be, not blood, more fluids to ooze out of the capillary and go into the surrounding tissue. So this is the interstitial fluid increasing. So congestion is occurring inside the tissue too, and this is causing the edema in the tissue, and this is causing the swelling of the tissue that would start choking up the bronchial pathway. So now this is happening, fluid is oozing out. Venular side will have the endothelial cells of the venules, they would start contracting, they would start shrinking. What that would do is that the intercellular gaps would appear and the fluids would spill out of that as well. So that is the increased vascular permeability. So as a result of that, we would have more fluid, we will have more fluid that has spilled out. So now we have gotten fluid coming out of the blood vessels for two reasons. Number one, there is increased permeability, and number two, there is increased blood flow because of the dilatation of the vascular beds. The result is there is going to be a lot of congestion inside the tissue. Then on top of that, the glands are secreting. So inside the bronchial lumen, that lumen is also getting filled up with the fluids. So imagine the system is shutting down, the bronchi is shutting, the airways are shutting down. Now so we have gotten the effect. So I was saying that if you summed up all the effects that are going to occur, the effects in the first phase are: number one, smooth muscle contraction or spasm; number two, increased permeability and increased fluid; and number three, vascular dilatation and increased permeability; and number three, increased secretions. That is it, there is nothing else happening. So histamine or serotonin or other things, the end result is one of these three: bronchial increased secretion, that may be the GIT or that may be the respiratory tract; the muscular contraction or spasm, that would create obstruction of the airway; and then the vascular bed or vasoactivity. And what is that activity? On the arteriolar side, dilatation, and on the venular side, increased permeability. This is the total action that is happening, and the result of that action is that severe congestion occur in the bronchus, and the bronchus would start collapsing or becoming narrow or choked. At the same time, the histamine has an effect on the smooth muscles as well, and so what happens is that smooth muscle would go in a spasm and they would contract. So that is one effect. This in itself is enough to cause serious problems. However, the story does not finish here. The granule that is degranulating also contains serotonin that also has similar effect like histamine, but minor and negligible. So normally we do not say that this is a big effect that is here. Then we have gotten the proteases and especially tryptases that are released. So now keep an eye on this: the tryptases that are released, the proteases that are released, they are going to cause breakdown of the proteins. What will that cause? Once the proteins are broken down, you would know that the bradykinins are going to be produced as a result of the tissue breakdown products, and secondly, the complement is going to be split as well. So the proteases are going to create split complement products, and they are going to cause a tissue damage. So this is the first thing where the tissue damage has started occurring, and many people including myself, we say that the complement does not have any role in the type 1 amino hypersensitivity reaction. But if you see here is complement. As soon as the proteases are produced, the complement is split and the complement is there to start creating the inflammation. So here now we have gotten even more of a problem, and that problem is that we have gotten the tissue getting damaged, so the cells are getting damaged, and number two, the complement split products are being produced, and these products are going to start the inflammatory process, and these products are going to cause the chemotactic action for the other cells to come in, like neutrophils and eosinophils and the monocytes. So the inflammatory process is going to start soon as well. So the story does not stop here, more things are released as part preformed granular stuff, and what are these? These are the neutrophil chemotactic factor and eosinophil chemotactic factor. So now what are we calling? We are calling other cells to come into this area as well. What are the other cells that we are calling to come in? Neutrophils and eosinophils. They both are inflammatory cells. They both are going to come here and cause damage and try to cause inflammation. So just remember what is happening right now in the patient's body within 30 seconds to 30 minutes, he has gotten his airways obstructed. He has gotten his airways becoming narrower, collapsed, spasmodic, with edema and with congestion. Same is happening to his GIT, same is happening to his skin depending upon the exposure. If it is the pollen that only went into the lungs, then this is only happening to the lungs, but if it is something that got injected or that got applied to the skin, then this would be happening in the other areas. So please remember the extent of the reaction is going to depend upon the type of route that is taken for the allergen to reach the body: inhalation, ingestion, or application to the skin. So sometimes if for example penicillin injection is given, then this is going to create a systemic anaphylactic reaction where respiratory system, GIT and the skin all are going to react. So this is the primary reaction and this is the primary response. If the patient survived, so what is going to happen in this case? The patient's airway is getting obstructed, so you should be ready to support the patient with the so keep the airway open, tilt the head to a side, try to make sure that the airway is patent. If not, endotracheal tube may be needed, if not even the thoracic surgery may be needed. So it depends upon the extent of the issue, but this is the area where this is the phase in which the patient actually may die if not properly taken care of. And what is the mainstay of the anaphylactic reactions treatment? The mainstay of anaphylactic reaction treatment is epinephrine. So EpiPen is a very common thing which is given on the top of the thigh in case of the exposure. So now let us talk about it, that while this happened, we have gotten the phospholipase A2 that is starting to act as well. So I am going to remove this, I will just leave diacylglycerol here for the sake of completion, and let us make a nucleus here. We need the nucleus now plus the okay. So now inside here what is happening is that the phospholipase A2 has become active, and that is, we talked about it, that would cause the arachidonic acid formation in the membrane, and arachidonic acid is going to form the prostaglandins and leukotrienes. This would not happen immediately, this would take some hours, and so this is the late phase. These two things that I am going to talk about now are the late phase reaction or late phase of the hypersensitivity reaction. So the first thing that we would talk about is the phospholipase A2 activation, arachidonic acid production, and the prostaglandin and leukotrienes. What is the effect of prostaglandin and leukotriene? Prostaglandin are potent bronchospasmodic agents, plus they are vasoactive systems, eicosanoids. So the result of that is, again as we talked before, that arterial dilatation, venular permeability would increase, plus the smooth muscle would become spasmodic. So that is the effect of the prostaglandins. Leukotrienes, there are three leukotrienes which would come here: LTB4, LTC4 and LTD4. So LTC4 and D4 are the most potent vasoactive substances. They would cause much more, thousands of times more potent than histamine, and when they will be formed and when they are released, this is going to be a lot of vasoactivity, and there is going to be lot of edema and congestion and increased permeability. So these two, and again I told you that please remember that the actions are increased permeability, vasodilatation, mucus secretion, and the congestion of the area. So that is what is happening here, and actually the bronchospasm or the smooth muscle contraction. So these guys, these two are the most potent vasoactive substances. So they are going to cause the further aggravation of congestion. LTB4 on the other hand is the chemotactic factor. So leukotriene B4 is going to start calling neutrophils and monocytes and other substances to come in as well. So that is another substance which would call other cells to the action and have the problem created. Prostaglandin are also bronchospasmodic plus the vasoactive, not as strong as the LTC4, but these would be doing the same action. So this is a delayed reaction, would be starting within the 2 hours to 8 hours. So the patient who came to you with the allergic reaction, mind you that within 2 to 8 hours that patient is going to experience another wave of effect, and you have to make sure that you either have the patient under observation within the ward or you have made sure that the patient is fully covered with the drugs. I usually would keep the patient with me for another 24 hours. Now one more thing that would happen as part of these activations for phosphokinase C, the nucleus would receive secondary signals as well, and as a result nucleus would create messenger RNAs. So some genes will open up, genes would open up on the nucleus that would create messenger RNA. Messenger RNA will now create cytokines. So that will be the next thing that would happen. So three reactions from this mast cell: immediate reaction of the degranulation, delayed reaction of arachidonic acid derivatives, and then cytokine production. What are the cytokines that are going to be produced here? Platelet activating factor will be produced, tumor necrosis factor will be produced, IL4, IL5, IL13. Why is this important? Remember IL4 and IL5? We said T helper cell produce them, mast cell produces them too, basophil produce them too, IL30, mast cell produce them as well. So interleukin 4, 5 and 13 are produced by the mast cell as well. Please do not forget, this is an excellent doctor would be knowing that. So platelet activating factor, tumor necrosis factor, IL4, 5 and 13 are also released in another few hours. These are cytokines that came in. What is their action? So platelet activating factor is a huge inflammation promoter plus platelet aggregator. So as a result of that, inflammatory process would start. Remember, the prostaglandin, arachidonic acid derivatives and cytokines that are being released as part of the late phase are going to cause inflammation. That is why I said that the second part of the allergic reaction is inflammatory part. So now the platelet activating factor is going to start the inflammation plus platelet aggregation. Tumor necrosis factor does a very interesting thing. What that does is, so if I make a big epithelial cell here, the TNF would come and act on this cell TNF, and the result is that this cell is going to produce eotaxin. Please do not forget that. So tumor necrosis factor activated epithelial cell, not endothelial, epithelial cell will produce eotaxin. Now what is the function of the eotaxin? Eotaxin is going to call two very important cells to the action. It is going to call T helper cells to come in, and it is going to call eosinophils to come in. Eotaxin, eosinophil chemotactic factor, it also calls in T helper 2 cells. So now that we have gotten the T helper 2 cells and we have gotten the eosinophils here, in addition to monocytes, neutrophils and other inflammatory cells, there is a war going on here, right? Now what would eosinophil do? Remember that eosinophil will produce major basic protein, and it would produce cationic protein. These two proteins are going to cause local tissue damage. Then this thing would also produce platelet activating factor and other inflammatory substances. This is eosinophil. and so again full blown inflammation would start happening here. This also produces histaminases, eosinophils, and they would try to ramp down the inflammatory process here. So to some extent eosinophils are going to be useful, but they are actually going to cause a lot of damage as well. Now what are T helper 2 cells doing here? After the eotaxins called them, T helper 2 cells would come in here and start releasing interleukin 4 and 5. That would aggravate the process, that would create more IgE, that would start creating further problems. So all of the cells that are coming in here, neutrophils, monocytes, eosinophils, T helper 2 cells, they are going to start a full blown inflammatory process and start causing damage here. So now what is happening? What is happening is not only the patient is congested, not only the airway is congested, edematous and narrowing, the tissue is getting damaged as well. And as the tissue damage occurs, more and more inflammatory response would occur, and this is a vicious cycle. How do we stop that? How do we help that? So this is the mechanism, early phase and the late phase. How do we help this situation? We need to break this cycle. So there are multiple things that we can do. So look at here. One is we can stop arachidonic acid derivatives from being manufactured, and we can do that through the glucocorticoids. Glucocorticoids can stop the arachidonic acid manufacturing and the derivative manufacturing by two ways. One, they can block the activation of the phospholipase A2, and secondly they can block the cyclooxygenase or COX1 and COX2 enzymes. So that is one. So glucocorticoids is useful. Second is epinephrine. So the very first thing to do, the treatment of the anaphylaxis, is epinephrine. What is the function of epinephrine? Remember, epinephrine have alpha adrenergic receptor activity and beta receptor activity, plus it has an increase in cyclic AMP effect as well. So epinephrine's increase in cyclic AMP will cause stabilization of the mast cell and the degranulation would reduce. That is one. Secondly, because of the epinephrine's effect on the alpha and beta receptors, the vasoconstriction would occur, so that is the reverse of the dilatation, and the vasopermeability would reduce and the blood pressure would go up and the congestion would start reducing. So that is the further congestion would, aggravation would actually stop as well. So that is the effect of the epinephrine. Of course you can give decongestants, of course, depending upon if the reaction is in the eyes or in the nose, and you can give cromolyn sodium. So what is the effect of cromolyn sodium? Cromolyn sodium would act on the calcium increment here. So diacylglycerol and working on the calcium channels. Cromolyn sodium actually reduces the calcium influx here and here, and that also stabilizes the mast cell. So these are some of the treatments to give as part of when the anaphylactic shock or the problem is occurring. Let us continue our discussion about the what is left here. Let me quickly see. We have done this, triggers, manifestations. We have done a little bit discussion about the treatment as well. So I think we have covered it for the most part. The important thing here once again is that the reference material, I used the Big Robbins and I used the Lange review of immunology and bacteriology. So I have used these two books. Inflammation and the allergies and some other topics should be done thoroughly from the Big Robbins or from other such good books. So I have done that. Let me just see from my notes if I have left anything else. So no treatments in general. Anaphylactic, we talked about it. Epinephrine is the first stay. We can give cortisols to block the arachidonic acid pathways. Then we can, so normally they say the treatment goes into ABC. A is keep the airways patent, B is keep breathing going, C is help the cardiovascular system to keep the blood pressure up, and the treatment is ABC as well. A is adrenaline, so give epinephrine. B is the Benadryls, or give the Benadryl derivatives, and C is the corticosteroids and give the corticosteroids. So these are the ABC drugs and ABC ways of treating. If there is rhinitis, one can give nasal decongestants. If there is conjunctivitis, one can give antihistamine plus decongestants or vasoconstrictors. and then what else, that is about it. The tests for the allergic reactions, that what is a patient allergic to, we can do the scratch test or we can do the other tests as well. So okay, thank you very much. Okay guys, so one more thing which I forgot to mention, and I kept thinking what was I missing. We were talking about the cytokines, and we talked about platelet activating factor, tumor necrosis factor. Mast cell also releases IL-4 and 5. You know the function of IL-4 and 5. IL-4 causes the IgE production and IL-5 is the chemotactic factor, or actually leukocyte activation factor. IL-13 is also released. It is very similar to IL-4. So one action is that it causes IL-4 like action, and the second action is that it causes mucus secretion. So having said all this, one final note, and that is the role of the IgE. At the end of the day, the people who are having this problem, they are having a problem with the IgE, and the IgE, increased production of the IgE is either because of the IgE receptor which is responding more to the IgE, or the T helper cell producing a lot of interleukin 4 instead of going to the cytotoxic pathway. So these are the type 1 allergic reaction. Then there is another thing called anaphylactoid reaction. Anaphylactoid reaction is a reaction that looks like anaphylactic reaction but is not. What is that? In that case, mast cells are degranulated without the IgE getting triggered. So there are chemical substances, for example the dyes, the dyes of various kind. These dyes can act, or drugs can act on the mast cell directly, and they can cause it to degranulate. So that kind of a reaction will be called an anaphylactoid reaction. Now what causes mast cell to degranulate? Mast cells are very sensitive. They are like the babies of the body. They can become degranulated in response to temperature changes, in response to mechanical trauma, in response to shower doing the temperature and mechanical action of the body. They get degranulated when the IgE becomes activated. They get degranulated when many other chemical substances can act on them. So they are very sensitive and they degranulate very easily. So thank you very much. That concludes our hypersensitivity reaction 1.